My name is Roei. I am the physician in charge for the treatment of histiocytic disorders at Asuta Medical Center, which is a large tertiary medical center in Israel. We treat a cohort of 24 out of the 38 patients in Israel. I tend to speak fast, so this is to the translators over there. I would need a reminder if need be. Anyway, I was asked to substitute for Dr. Estrada Veras, who unfortunately could not arrive, and we had concocted a presentation just today. And thinking about what I want to present after going into so much detail during this day was more of an overarching strategy for us, for patients, and for their physicians to take the therapeutic process and make it as best as possible. So the name of the talk is Let's Get Things Straight. I'll be entertaining you this fine afternoon with this talk. And we have 5 chapters in this talk. Chapter number 1, stop the train, I want to get off. Chapter number 2, what you see is not what you get. Chapter number 3, luck favors the prepared mind. Chapter number 4, pneumono-ultramicroscopic silicovolcanoconiosis. You don't have to translate that. And chapter number 5, frankly, my dear, I don't give a damn. All right. So let's get real. I myself, as a physician, was also unfortunately a caregiver of a sick family member myself. I know very well the feeling of being helpless, of being overwhelmed. And in fact, when a patient is presented with the diagnosis of a malignant condition, and specifically a rare malignant condition, who not many physicians know how to manage, they may feel helpless. They may feel overwhelmed. This feeling of being overwhelmed is completely legitimate. It is a challenge that needs to be coped with on the best level. So the best way, I believe, to address anxiety, to address fear, is to understand what we are doing, to try to increase the levels of certainty in the entire process, the entire day, from waking up in the morning up until doing your everyday life, which is a very important part. It's actually the most important part of the process. And of course, there are the tests, there are the patient-physician follow-ups. So what are we doing? In my clinic, I always outlay 4 major challenges in the management of the histiocytic patient. First and foremost is establishing the diagnosis. We had an amazing talk by a representative of the Mayo Clinic who showed us that for some patients, ECD is actually not ECD. We should be critical towards ourselves and be sure of the diagnosis. So this is the first challenge. Challenge number 2, given that we have validated that ECD is indeed a disease, it would be prudent to evaluate the entire disease burden. Is the brain affected? Are the bones affected? Are the kidneys affected? Which organs pose threat, discomfort? Which should be addressed first? Third challenge would be to tailor therapy and to address the complaints. Nausea, pain, balance issues. Tailoring targeted therapy, which is molecule-specific, mutation-specific. And eventually, the long-lasting challenge would be to monitor for response and potential toxicities and to ensure the patient with the best quality of life and, if possible, also long life as much as possible. So how do we cope with this overwhelming news? How do we cope sitting in that chair for the first time and hearing the news? So after the shock, I would advise anyone, this is what I would have done if I were a patient. The first step is to choose your companion. And my term on this matter is a governing physician. You all know very well that if we look 10 years backwards, 12 years backwards, a patient with brain disease would have presented at a neurologist. A patient with bone disease would have seen an orthopedic surgeon or a rheumatologist, right? And today, we know very well that we need a governing physician, a medical professional that would take a step back, look at the entire patient, and address each location per what it means clinically. So what do we require from this physician? We want him to be ECD savvy. I don't know if you understand, if you appreciate the strength, the robustness, how powerful this organization is. What Kati has done for this organization and the entire ECDGA community. This is huge strength. Think about other diseases that do not offer such a strength. So, one, that would be knowledge. Two, that would be willingness to learn new things. I learned a lot since 2014. I learned how to manage ECD patients here. Three, the physician should be a person that you feel comfortable to talk to ask questions, sometimes again and again until you understand. Someone who would be a true companion and provide you with the information that you need. So that is the physician. You see, open and efficient patient-physician communication. Now it is not simple in real life as it is simple on the board. Because truth be told, we are very busy. So the extent of communication and depth of communication should be calibrated and divided over several meetings. Don't be angry if your physician is at times very, very tense, because he will most probably stay in his clinic up until late. And when he is not, we can elaborate further. Now, the key element of fear is uncertainty. Not knowing is the most, in my experience, is the most frightening thought. So the joint mission would be to decrease this amount of uncertainty, and how we do it? By building a roadmap of what we are going to do from now up until to the point that we get to our satisfactory response, to our satisfactory condition. So this is chapter number 1. Chapter number 2. What you see is not what you get. Short story. A new patient arrives at my clinic, and she enters the room, and she is distraught. She's full of fear. Because in the waiting room, there are other patients waiting, and they are all neurologically compromised. They are all in wheelchairs. And she's a newly diagnosed woman, and she enters the room, and the first question she asks me, is this going to happen to me? Uncertainty, fear. So we have to address a few biases here. This is a United States bomber from the Second World War. The Institute for Naval Research analyzed the hitting pattern of these aircrafts which returned from battle in order to think, okay, where can we fortify the aircraft so it would withstand battle better? But there is an inherent bias here, because these are not the problem. The problem are where the aircrafts were hit and never returned to base, right? So this is a bias. This is a survival bias. And I'm talking about an observer bias. I'm talking about looking at what you see at the waiting room and extrapolating upon yourselves. This is not true. Patients diagnosed 15 years ago, before the molecular era, before vemurafenib and cobimetinib and trametinib and dabrafenib, are principally different from people who are diagnosed today. Another issue is the acquisition of knowledge. we know nothing. The extent of what we, me and you, do not know is far greater than what we do know. Knowledge is a gift, but it is also dangerous. We have to address facts, and we have to give them the proper weight. Not everything that we read online is true. Any reasonable, healthy individual that would type in Google that he has a headache and is looking to self-diagnose would find out eventually that he might be suffering from a bleeding to his brain or from a tumor in his brain. That's horrible, right? But it's not the case in the vast majority of people. And here's an example. You know, we use PET-CT for global disease assessment. And some of my patients cannot wait for the formal interpretation of a radiologist. They take the CD that they receive about 1 hour after the examination, and they look at it in a computer, people with no medical qualifications. What we can know is that if we use Google intelligently, maybe also YouTube, we can try to interpret. And what we know, what is PET-CT? PET-CT is a nuclear medical examination that allows us to see areas in the human body that are metabolically active. If it is hungry for sugar, it's a hotspot. If it is not hungry for sugar, it is not. The brain, for example, which is a very healthy organ, is PET avid, is FDG avid. It sees the isotope because it's constantly consuming sugar. And here we can see this large mass. This really catches the eye, right? What is this? What are we seeing here? This is a pelvis of a patient. The patient is lying down on his back, so this would be the front, this is the back, this is right, and this is left, because he's now with his head into the wall and legs towards you. And you are seeing here the hip, the upper part, the proximal part of the hip, and this is the disease, by the way. And you see here the urinary bladder. This is actually contrast material in the urinary bladder. This is not disease. So the premise that hot is bad and cold is not true. So beware of trying to self-diagnose and to self-interpret. You have an urgent need to know, if your physician has time. Try to address it together. Here is another patient. This is what I said. Look, before and following treatment with cobimetinib, the heart, which loves sugar, and the brain, which also loves sugar, are PET avid, as opposed to the knees, which are responding. So there is more to ECD and management than meets the eye. How can we address these issues? So first of all, acknowledge that information is everywhere. Acknowledge that some of it is true and some of it is wrong, is not. Acknowledge that some information that is true today might not be true tomorrow. I encourage you to learn, but use validated sources. Learn how to use from validated sources. It's very dangerous to learn from hearsay, from people who are not qualified, on Facebook, on social networks. Disinformation and cherry-picking of facts can lead to significant anxiety, which is completely pointless. Despite what some people think, no, vaccines do not cause autism. Understand that you are unique. Not only that you have a rare disease, you as a patient with a rare disease are unique. The amalgamation of symptoms, of systems involved in you, your mutations, your genome are unique. And therapy should be planned for you as an individual. Beware of charlatans. To my dismay, I have seen people taking advantage of ECD patients in Israel already. Already, people are offering false hope for a lot of money. Beware of these people. Chapter 3. We have overcome the sense of being overwhelmed. We are now ready to begin the journey. Luck favors the prepared mind. You know this guy, right? I hate Apple products. Only Dell for me. But this guy is a genius. This guy managed one of the largest companies, changed the world, changed the face of the world, and managed his pancreatic cancer in parallel. I encourage you to take the wheel in your hands. Manage the disease. Do not let the disease manage you. What does it mean? It means that we want to be prepared. Let's be practical. Let's be the chief executive officers of our disease. When you are in a particular follow-up, in a particular physician-patient encounter, summarize the key issues. There is a lot to take in. There is this PET CT that you have to do, and brain MRIs, and cardiac MRIs, and complete blood counts, and dermatological examination, and sometimes you need a cardiac echo if you're on MEK inhibitors, etc., etc., etc. Summarize and prioritize together the action items in writing. Don't tell yourself, I will remember now and write afterwards. This is a poor strategy. Once you have done it, and you start addressing the different items on the checklist, then come prepared to your next follow-up. Have everything printed. Have everything prepared in an orderly fashion manner, because if you turn the process to being more efficient, you have more time to share your fears, to talk on a paramedical level. We acknowledge that sharing fear and anxiety decreases them. However, we are short on time, right? So making time would be wise. If you have questions, and questions do arise, write them down. Come with a list of questions that are burning for you. It's legitimate under these circumstances, under the ECD, under the rare disease circumstances, that a physician wouldn't know the answer sometimes. I sometimes tell my patients, I do not know. Sometimes nobody knows. But if we do not know, let's find out. Chapter 4. Pneumono-ultramicroscopic silicovolcanoconiosis. I didn't know this is translated in real time, so get them a cup of coffee in that room there. A patient of mine, Sir Indiana Jones, comes into the clinic and tells me, listen, I'm not feeling so well. Oh, so Mr. Jones, what is the problem? Well, I've been having difficulty breathing now. What have you been doing that made you in this condition? Well, I've been hunting a treasure, well, in a lost city near a volcano. Let's do a CT. Okay. It appears that you have pneumono-ultramicroscopic silicovolcanoconiosis. Scary word. By the way, it's not a real disease. It's a puzzler's word for silicosis. But I use it here to exemplify that medical jargon is complex. Again, uncertainty, again, anxiety. But if we learned it, you can learn it as well. So it's all about breaking down terms. You see, this complex word actually means this is a disease of the lungs that is caused by inhalation of very fine particles which are of silicon volcanic origin. For example, and you get a lot of jargon. If there is a particular word that distresses you, you can find out what it means. So understanding medical terms, this is what we said now. Complex medical terms can be frightening. This can be broken down to reveal their meaning, increasing certainty and decreasing anxiety. And communication is key. This is what we said in chapter number 1. This is all about the ability to communicate with your physician, to verbalize your needs. And receiving information, receiving an explanation for more than one time is indeed legitimate. Final chapter. Frankly, my dear, I don't give a damn. It's a shadow, the disease, right? It's always here above our heads, in the back of our minds, always picking, always annoying. But you are not the disease. You are a complete, whole individual with an entire life to live and to enjoy, now, not later. So my advice first and foremost, out of the medical settings. When you are in a coffee shop, we are in Italy, by the way. When you're in the coffee shop, on a trip, when you're enjoying life, there is no room for thoughts about PET CTs and tumors and BRAFs, and it's not interesting. Nobody cares. Okay? A good strategy would be to hope for the best. If you would have told patients in 2005 that we are going to locate a mutation and we are going to pinpoint that mutation and we're going to use a targeted therapy and the entire disease or near entire disease would shut down metabolically, they would not have believed you. But progress is being made. So it's important to maintain optimism. But, it's a big but, we have to accept the boundaries and limitations of medical science at a given moment. This is acceptance. Accept what we can't change now and hope that we will be able to change it for the better later. And, since we are strategists now, let's prepare for the worst. Let the worst come, and we shall address it, and we shall face it, and we shall overcome. And finally, life is beautiful. Find time to smile. Your outlook on life would influence your quality of life. I hope for you for the best. Be well. Thank you very much.